I can't promise it'll be life-changing, but hopefully it'll be informative. So thyroid eye disease is a vision-threatening disorder. It's got multiple associated complications. Those include progressive optic neuropathy, keratopathy, and posterior proptosis. Now, kind of for a long time, the treatments for active disease have been pretty limited. They've studied a lot of different things, but really what they found that works is high-dose corticosteroids with or without concurrent radiotherapy. And both of those are not without their side effects, complications. So there's definitely a need for additional therapies to help with this pretty common disease. And then kind of as complications arise, orbital decompression becomes an option where you release pressure in the orbit by increasing orbital space. So that's kind of been the paradigm of treatment for thyroid eye disease for a long time. But now we've introduced teprotumumab. The trade name is Tepezza, and what this is an inhibitory monoclonal antibody which targets insulin-like growth factor receptor 1. Now, from med school, we all learned that thyroid and Graves' disease are caused by thyroid-stimulating hormone antibodies. So that kind of raises the question: how does an insulin-like growth factor receptor antibody help with this problem? So I'll try to explain that a little bit. So in thyroid eye disease, your body's plasma cells are creating immunoglobulins, those thyroid-stimulating hormone immunoglobulins, which bind to receptors. Now there's a thyroid-stimulating hormone receptor, and then coupled to that is insulin-like growth factor receptor. And both of those are activated in fibroblasts, causing the fibroblasts to increase the production of hyaluronic acid, which increases volume in the orbit, leading to those compressive complications that we see in thyroid eye disease. That's where the insulin-like growth factor receptor comes in. So in Tepezza, you infuse antibodies against that receptor. It binds to it, blocking the thyroid-stimulating hormone antibodies and preventing activation of those fibroblasts to reduce production of hyaluronic acid. That's how the medication works. It was approved very recently, so it's the first FDA-approved therapy designed specifically for treatment of active thyroid eye disease. It was just approved on January 21st, 2020. So really an emerging therapy here. All right, so now that kind of intro is done, we'll move on to our study. For those who don't know, that's my dog, Ruben. Clearly doesn't care if you can see or not. It's fine. All right, so our study, what our purpose was just looking at whether or not management of thyroid eye disease has changed here at Kentucky since FDA approval of teprotumumab. So specifically to look at that, we wanted to see if the rate of orbital decompressions changed before and after, and if the patient characteristics of those who underwent orbital decompression changed as well. I'll go into detail about that. So we conducted a single center retrospective review of all the thyroid eye disease patients cared for by the Oculoplastic Service from 2012 to December 31st, 2021 with IRB approval. So we're able to include 629 patients in this study. 472 of those, which had their first exam prior to that kind of date of Tepezza FDA approval, and then 157 with their first exam after that date, which is how we used to compare the two groups. So pretty good sample size, thankfully, because as you know, Dr. Timoney sees a few patients every day. Our primary outcome was the orbital decompression rate. So we calculated this by just dividing the number of patients who underwent orbital decompression by the number of patients seen for thyroid eye disease during each specific time period. So we performed this rate before and after that teprotumumab approval in January 2021, and then compared those two rates with chi-square testing with a p-value less than 0.05 considered significant. As far as kind of our additional outcomes, the two things we looked at were what were the indications for decompression, and then what were the pre-treatment clinical activity scores of our patients. So for those who haven't heard this concept before, CAS or clinical activity score, it's how you quantify the level of inflammation in thyroid eye disease. So you take on initial exam 7 components, including some symptoms and some signs clinically of thyroid eye disease, and you give a person a score for each one of those, a value of 1. And so it ranges from 0 to 7 initially, with a higher number indicating greater level of inflammation. When you see patients for follow-up, there's a few more items you can add, such as like increasing proptosis. So finally, you get a score of 10. So active disease could indicate a score of 3 or higher on the initial exam or 4 or higher on follow-up. But basically, higher CAS means more inflammation, more severe disease. So going to kind of our data, these charts show how the orbital decompression rate changed before and after teprotumumab approval. So for patients seen prior to approval, we had a total of 472, 91 of which underwent decompression. Some, have undergone decompression. So that equated to 19% of those patients. After teprotumumab approval so far, we've seen 157 patients, of which 13 have undergone decompression, which equates to 8%. And through the statistical analysis, we found that to be a statistically significant decrease in orbital decompression rate, which is illustrated on those graphs there. As far as the indication for decompression goes, there were 2 indications that we found for our patients. So either patients had severe compressive optic neuropathy or severe exposure keratopathy that can be managed with other treatments. So before Tepezza approval, the most common indication was compressive optic neuropathy at 56%. But actually after teprotumumab approval, we've seen that as kind of flip-flop. So these patients, it's been more common for them to get a decompression for exposure keratopathy instead. And that was, again, statistically significant. And then finally, we took the means of all these patients, their mean CAS score, and compared them. So before Tepezza approval, the mean CAS of patients who did undergo decompression was 2.67 versus after it was 3.23. But those were not significantly different. There's overlap of the standard error. So that did not change, but we also looked at how many patients with a CAS greater than 4 underwent decompression and what the rate of those decompressions were. So that actually did show an increase. So it went from 18% of the decompressions were done on patients with a CAS greater than 4 before January 2020 versus 53% of patients who underwent decompression at CAS greater than 4 after. So showing that a higher proportion of patients with severe disease were undergoing decompression afterwards. And then finally, just wanted to talk about kind of the characteristics of the patients that we've had on Tepezza so far. So a small number, 8 patients were placed on the medication during the study period. 6 of these completed treatment, so it's an 8-week or 8-dose treatment course, from my understanding. 1 of those was currently undergoing treatment at the time of finishing up the study, and then 1 had to discontinue due to an adverse event. She was having issues with hypertension, which is not for sure caused by the Tepezza, but she decided to discontinue after talking with a primary care physician. So I kind of wanted to see, it's a small number. I wanted to see how, if these patients weren't on Tepezza, that might affect the data. So if these had all instead had to undergo decompression, our rate would have gone up from 8.2% to 13.3%, which would no longer have been statistically significant than the rate from before. That's not to say that these patients would have all required it, but it does show that kind of with the small sample size we're dealing with, there's a possibility that the introduction of Tepezza did affect those rates significantly. And so just kind of to summarize the results, so our rate of orbital decompression has decreased following the introduction of teprotumumab. The most common indication for decompression has also changed. So initially it was compressive optic neuropathy, but since January 2020, exposure keratopathy has been the most common indication. And then finally, our mean CAS of patients undergoing decompression was not affected, but the rate of patients with a CAS greater than 4 who underwent decompression has significantly increased. So finally, to talk about kind of some conclusions that we may be able to draw, I'd say these results indicate that since introducing Tepezza in clinical practice, that may allow physicians to manage medically patients who would previously have required surgical intervention, or potentially just push it down the road a little bit. And with anything, there are risks involved with surgery. So the ability to prevent that or put it off for a while until patients are more stable is certainly going to be beneficial. In turn, the individuals that do end up requiring decompression may end up being those with more severe clinical disease overall. And that could be indicated by the fact that there were more decompressions on patients with CAS greater than 4 since the approval. And then finally, I'd say I don't know how much you can make of the increased proportion of decompressions for exposure keratopathy, just given that there's only been 19 decompressions in our data set since January 2020. I just don't know how much of the clinically significant result that is versus just it's early on. We don't have a ton of data on that. And then some areas that I think would be really interesting to study going forward would be looking at the outcomes of patients treated with decompression versus Tepezza. How does their vision turn out? How are they, their satisfaction, diplopia, measures like that, looking more at outcomes, and is one better than the other? And then finally, I do wonder how many of these patients that are treated with Tepezza now will end up going on to oral decompression in the end. Does it just kind of put off things, or does it prevent it from happening altogether? That's about it. Here are my sources that I've used, and I'll go ahead and open up the door to any questions. So from my understanding, from working with Dr. Toomey, the drug company's actually been pretty good about getting people on it without, I think even if insurance doesn't approve it, they've got like compassionate use. And I haven't seen anybody where we've been like, you would be good for this, but can't pay for it yet. No. You know how much it costs? It's incredibly expensive. It's hundreds of thousands of dollars. Yeah. Mm-hmm. Yeah. So I think as of right now, they've done a pretty good job of getting people who need it having it, but I don't know how they'll, 5 years down the road, are they going to change that, or are they going to need their money? Hard to say.
How long are you on?
So it's kind of a defined course. I believe you get 8 infusions and then you're done. So it doesn't take too long.
8 doses. 8 doses, 3 weeks apart, 24 weeks. See improvement after like 4.
Yeah, pretty quick. And one of the most common reasons I've seen people not be able to get it, it does have risk of ototoxicity. So anybody with hearing problems, we're kind of steering away from it. Yeah.
Insight on, I was just looking at the proportion of patients that you saw before and after 2020. It seems like after 2020 there was maybe 3 times as many patients in the same time period. But again, why that would be true? Is it possible that before 2020 there was some difference in documentation, the milder cases when documenting thyroid disease?
Maybe. I'm not exactly sure, or if just records were not quite as easy to access back then. I didn't. Ryan did a lot of the kind of early data collection. I might check with him about how reliable the data is from back then. That's a good point. Yeah.
I'm just wondering if there is some bias there on the data, and compare like to somebody else because there's such a small number of patients in the first years that it can be diagnosed with those symptoms once a year.
Yeah, that's a good point. All right, I guess I'll turn it over to Garrett.
Thank you, Peter Blosser. So next we have Garrett Oberst, and he will be presenting on factors influencing tube shunt erosions and postoperative outcomes at 3 years following the tube.
All right, so like Angela said, I'm Garrett. I'm one of the featured white-tooths as well. My project's titled Factors Influencing Tube Shunt Erosions and Postoperative Outcomes 3 years Following Tube Shunt Surgery. Same objectives as Dr. Blosser's. All right, so a little bit of background about tube shunt erosions. Probably the biggest study that we have that looks at these is the tube versus trab study. And at 1 year, it shows a 1% risk of exposure, and this is for all tube shunts, kind of regardless of technique that were included in that study. And then at 5-year follow-up, a 5% risk of exposure. There was a few more studies, one from Koval, which looked at 41 cases from 41 patients, and they were matched with two controls. There's a total of 121 eyes from 121 patients, and they're trying to look at what factors can influence the risk of exposure here. And they found Hispanic ethnicity, neovascular glaucoma, a combined surgery, like a combined cataract, or previously undergoing a trab would increase the risk. Again, another retrospective study here looked at 1,073 adults. There's 67 total exposures over this time. They found that female, gender, and white race were associated with increased likelihood of exposure. And then another study, and this has been more popular recently and something that people have been discussing, is does anti-VEGF therapy maybe increase the risk of tube shunt erosions? And they found that there were no difference in number of erosions, but there was a difference in recurrent erosions with anti-VEGF therapy. And so our project looked a little bit at this somewhat new technique. It's a scleral tunneling technique for tube shunt surgery. And essentially what that means is, and I'll have a picture later, but the tube shunt kind of dives in a little bit farther back. And so the idea is that maybe we can prevent the need to use patch grafts and have a little deeper coverage of that tube shunt. I had initially thought that it was developed to decrease post-op erosions, but it turns out it was actually developed in 2016 after reimbursement for patch graft materials ended. And so there's been a couple studies on this, not a lot of, I guess, big ones so far, but one followed 78 eyes and found a difference between erosions in those undergoing a long tunnel, which is what we were kind of talking about in this study, 2.5% versus the classic pericardial patch graft, which had 8%. And then there was another series, this was one of the earlier ones, but they looked at 9 eyes of 6 patients using a Varvelt, and there was no significant difference between postoperative outcomes, whether or not the tube was tunneled or not tunneled. And so when we're talking about a tube shunt erosion, this is what it looks like. As you could probably guess, that is supposed to be covered by the conjunctiva, and in this picture, the arrow is pointing to it completely exposed. And this also demonstrates the classical technique where this mouse works. It kind of dives in right here, just basically right at the lumbus almost. There aren't a ton of great pictures of the tunnel technique online, but this is one of the better ones I could find. So you can see that the track is being made a little more posterior here than kind of your classic tube shunt. This is a PK. I'm not really sure why that's on there, but it kind of came with the other picture. I hope they weren't doing that at the same time. And here you can also see that needle diving in just a little bit farther back than we would have, I guess, classically thought. So the purpose of our study was to determine factors influencing postoperative erosions following tube shunt surgery here at UK. So the data that we drew from was all of the tube shunt surgeries performed at UK between 2013 and 2021. This was a retrospective chart review. And for this preliminary analysis, we looked at charts from 2016 and 2019, and this was prior to and following the use of the previously mentioned scleral tunnel incision. And we wanted to be able to follow these people for a few years, and that's also why those years were chosen. We followed out for 3 years, since one of the years was 2019, and our primary outcome was erosions at that postoperative date. Secondary outcomes included IOP, visual acuity, number of glaucoma medications as well. Other data collected, we looked at basic demographic data, the type of glaucoma. As you can imagine, pre-op chronic topical steroid use is something that could influence wound healing and remodeling after surgery. We looked at pre-op and post-op anti-VEGF injections. We recorded data, visual acuity and IOP, number of glaucoma medications, et cetera. And then maybe most importantly, we recorded the shunt type, patch graft, whether or not one was used and what type, whether or not the tube was tunneled, the quadrant, the surgeon, if they underwent further glaucoma surgery, and if there was any erosion within those first 3 years or any erosion at all, even after those first 3 years. So baseline patient characteristics of the study, you can see, I think it's fairly reflective of the population that we have here at UK. We had 125 patients included in these 2 years, and pretty equally distributed between gender, laterality. You can see that we did have 38 combined with a cataract, 87 without, where it's just a tube shunt alone. 28 patients did not get a patch graft, and 96 did get a patch graft of some sort. And so looking at erosions at 3 years, and this is for all 125 patients that we included. Fortunately, there were only 3 erosions, but that kind of makes it hard to draw a lot of conclusions from this data here. So you'll see that in 2016 and 2019, really no significant difference here. When we look at race, which was something that was previously mentioned, we did have no erosions in our African American population, although we did only have 25 patients of that. When we look at patch graft used, we had 2 erosions when a patch graft was used, 1 when there was no patch graft used. 1 erosion in the topical steroid group, although that's a pretty small group as well. And then when we look at combined cataract surgery, we didn't have any erosions in the group where cataract surgery was combined. I will say that the pre-op VEGF number there, kind of based on how we were doing the data collection, it's chart review. Some of that was in AEHR and some of that was from 2016. Some of that is also from satellite clinics. And while our notes are always in there, if they were referred from somewhere else, even if they had a diagnosis of neovascular glaucoma, sometimes it wasn't clear whether or not they did get an anti-VEGF injection. And so I would suspect that the number of pre-op anti-VEGF injections is actually higher than it is, but this is only the amount that I was able to confirm based on chart review here. And so, as you all know, working here, that we do lose some of our patients to follow-up after surgery, whether it's transportation, health issues, or just them maybe not knowing or understanding that they need to come back. And so I wanted to exclude the patients that didn't follow up or didn't have at least 1 year of data after the surgery, because they could have had an erosion and we could have not known about it. And I think it's important to take into account, were we actually able to see these people to follow up with them? Again, there's no statistically significant difference of any of these here. It doesn't really change a whole lot. You can see with race that it's still the same. Patch graft, more or less kind of the same. Topical steroid use, tunneled incision, combined surgery, and anti-VEGF, more or less looks pretty much the same as before. So when we're looking at post-op visual acuity, again, this includes all patients, and we'll break it down by patients that underwent combined cataract and tube shunt only after this. Again, no statistically significant difference in visual acuity here. So we can see overall, and this is expressed as the difference in logMAR visual acuity, but in parentheses, you can see that converted to Snellen here. So overall, pre-op, patients had about an average of 2091 vision. And you can see these negative values. Unfortunately, vision tends to worsen after tube shunts over time, but these patients also have glaucoma severe enough that they're getting a tube shunt. So vision's probably going to worsen regardless here. You can see here in the tunneled group and here in the untunneled group, the difference in change in visual acuity, and that more or less these look really about the same here. No statistically significant difference. It's also important to note that this slide includes 69 patients that had a full 2 years of follow-up of visual acuity data. It would be possible to break it down and keep those patients in for post-op month 3 and post-op year 1, and then kind of take those patients out as we lost them to follow-up. But I think if we're looking at the change, if we're comparing post-op month 3 to post-op year 1, wanted to keep those same patients in for the purpose of this analysis. Here's the visual acuities for combined cataract. Again, not statistically significant, but I think we do kind of see a little bit of a difference here maybe. So for the tunneled group, you do see that the vision to start out was a little bit worse. It was on average 2150. And in the non-tunneled combined cataract group, the initial visual acuity was 2080. You do see that vision was more likely to improve over especially that first 3 months and first year in the tunneled group compared to the non-tunneled group. But at post-op year 2, those kind of normalize out. Again, this includes 22 patients that had a full 2 years of visual acuity follow-up data. For the tube shunt only, we really see no significant difference in change in visual acuity as well. And this includes 46 patients that had a full 2 years of follow-up data. For post-op intraocular pressure, the good news is that both techniques seem to decrease intraocular pressure pretty significantly here. So overall, at post-op month 3, an average of 11 points lower, and then 12, and then 13 at post-op year 2. The tunneled and untunneled groups, again, while not statistically significant, maybe a little bit lower in the tunneled group than the untunneled group here. This includes 70 patients that had a full 2 years of post-op IOP data. And here it is expressed graphically here. You can see the top line here is the untunneled group. The middle line is the overall, both groups combined, and then the bottom line, the dark blue line, is the tunneled tube shunts. And when we're looking at postoperative glaucoma medications, we can see that pre-op medications in both groups were about the same. For the tunneled group, there was a statistically significant difference in number of glaucoma medications at year 1 as compared to year 2. And again, or at year 1 as compared to the untunneled, and then not statistically significant, but still a difference at year 2 as well. And here this is expressed graphically as well. And this only includes the patients who had 1 year of follow-up. So in the tunneled group versus the untunneled group, there was a lower rate of tunneled or of repeat glaucoma surgery in the patients that underwent tunneled incision. And then by patch graft use, there was really no difference at all. This includes 94 patients, and we excluded SLT or cataract surgery, as these aren't really considered, I guess, major surgeries for these patients. So a little bit of food for thought. We mentioned that one of the benefits of the tunneled tube shunt is that you would likely not have to use a patch graft, or patch graft is kind of optional with this technique. So the Tudiplast cost to UK is $265. The billed amount that we bill patients and insurance is our cost times 275%. So that's about $1,000. If we use a scleral patch graft, that costs UK $600. We bill about $2,200 for that. In 2016 and 2019, we performed about 122 shunt surgeries in each year. We'll likely perform more than that in the future as we have additional faculty members and additional ORs now. So let's say that we did perform 120 in the next year. The savings to UK, if we didn't use a patch graft on these patients, would be somewhere between $16,000 and $54,000, and the decrease to the build cost would be $90,000 to about $200,000. Now, not every single patient is going to probably qualify for this, but that's kind of why we put the possible range on there. I think it ties in well to our grand rounds from last week. We were talking about how to keep healthcare costs down for both the system, the patient, insurance. So I think this is something to consider and kind of think about moving forward. So the limitations of our study. Current data shows that the relative risk of a tube shunt erosion using a tunneled incision is about 47%, but the absolute risk, or the number needed to treat for that, is actually pretty high because of the low rate of erosions. And in this study, we had a low rate of erosions. We only had 3 erosions. And the ideal test for that would actually be I think it's a Fisher's exact test for independence. I used chi-squared analysis for all of the rate comparisons and a t-test for all of the average comparisons. So I think that we probably need a bigger number to be able to draw actual real conclusions from this. But this kind of lays the groundwork for us to move forward and do that a little bit. The small number of erosions within the time frame as well. We're only looking at 3 years of data. Tube shunt erosions happen, 3, 5, 10 years down the road, and so we're not capturing every tube shunt erosion from every difference in incision that was made. We had more tunneled tubes performed in 2019 than 2016. Only about 22% of the tube shunts performed in 2016 were tunneled, where 84% of the ones in 2019 were tunneled. Then almost half of patients were either lost to follow-up or had incomplete data of some sort. They missed their post-op year 1 appointment or their post-op month 3 appointment, or we just didn't have any more data from them. And that's going to be kind of an issue, kind of regardless. Future directions here would be to extend the follow-up period and to continue to collect erosion data. If we follow this out 2 more years, what does it look like? Is there any difference? Does one group start to have more erosions than the other group? And determine if there's any difference in outcome between the tunneled incision with and without the patch graft. So when I was talking about with and without patch graft materials, there were no patients who didn't undergo a tunneled incision who didn't get a patch graft. So every patient that underwent untunneled incisions got a patch graft. And we also maybe would include additional years in patients just to kind of appropriately power this and increase the reliability of the statistical analysis. I will say that in looking at the 2016 data moving forward to 2022, there were 4 additional erosions in the untunneled group, but we don't have data for most of the tunneled tube shunts for that time. So it would be kind of interesting to follow those out 3 more years and see if that's a real difference or see if that's just a difference we have because we're capturing more data. So kind of conclusions here. At 3 years, there's no statistically significant difference in erosions between tunneled and non-tunneled incisions. There's some concern for long-term erosions of the non-tunneled tubes, although additional follow-up is needed to see if this is a real difference. So possible decreased need for IOP lowering medications in the tunneled group, although the difference in IOP was not statistically significant. So it's unclear, whether or not that was just patient population or kind of what. But if there truly is no significant difference in the outcomes here, a non-tunneled or a tunneled incision could save patients, institutions, and healthcare systems significant money by not needing a patch graft as well. So further analysis is really needed to determine if clinical practice should be changed here. So thanks to Dr. Moore, who's helped a lot with this project, as well as Monica Jacobs over at CAS for getting us all of the cost data for the patch graft materials. Any questions? Here are my references.
The surgery itself with or without patch graft is taken about the same amount of time, or is there a difference in terms of how long?
It's faster without that.
The one thing about that.
This is a great demonstration of how if you cling to tradition, you do wrong. And yeah, we all thought that we would see a lot of erosions, and I think that the most significant thing is that we didn't see an explosion of erosions at all. It's cheaper and easier.
You do the tunnel with a needle or with a beaver?
20 degrees cheaper.
You're a great job. I have a question that's actually really long in the comment.
Okay.
But I think Dr. Sanders and Sach can attest that we had more than 3 erosions this year, unfortunately. So we are. But anecdotally, to me, it seems that the majority of those erosions are coming from non-tunnel tubes. So we're seeing continued non-tunneling technique in terms of probably this study. So I'm hoping that as we end this out and look towards
Coincidentally, there's an erosion going to the OR this afternoon.
Was it tunneled or untunneled? Yeah. Dr. Bastos.
I just have a question.
Yeah.
Comment as well. First of all, great job gathering all the statements, a lot of things to get. Congratulations. A comment regarding the loss of power upgrade.
Mhm.
An extremely high rate that can easily invalidate the findings in the study.
Mhm.
So I don't know if there's any way that you can reach out to the loss of power location for some of them at least to see if there's any records somewhere else that you guys could probe into, to see if there were documented erosions in other providers that we went to, or have them come back, try to reach out and have them come back and see about those erosions. I don't know, 50% loss of follow-up is just, oh.
Yeah, yeah. I think it was 30 patients. It was about 25% in the first year. And then, yeah, almost half had either one visit that they didn't come to, or yeah, like one piece of data
And
missing.
you're only looking at 3 years, and you want to look at further down the road because the erosions take a little longer.
Right.
You might even end up with an even higher rate.
And we're gonna have more, yeah, over time.
That introduces so much bias in your study, that's the conclusion part of them not very.
Right. Yeah, because
That's
I would assume that that some of our sicker patients that may have more problems with wound healing and things that may have had an erosion otherwise, may have been lost to follow up, or so. Yeah, it definitely would impact things. All right.
Okay, thank you, Garrett. Our next presenter will be Paris Vora, and he will be presenting on fundus indirect digital ophthalmology.
I don't know if you can see me or not. Oh, I'm not as tall as them. All right. Well, hello, everybody. I'm Paris. I'm one of the PGY2 residents as well. I'll be presenting a project that didn't require a lot of data gathering. So a little bit of a change in pace. This is more of a personal project that the department was willing to let me work on all year. The subtitle of this will probably be Paris probably has a little bit too much free time. And so I'll be just talking about this project that I worked on all year. I do have a not really financial disclosure. I have a patent on an image processing technique that I worked on with Dr. Albuquerque when he was here. I don't receive any royalties, unfortunately. So my objectives are, the same as the rest of the talks, but I just wanted to review indirect ophthalmoscopy and what some of its current limitations are, in my opinion. Some developments that have been made in digital indirect ophthalmoscopy. And I just wanted to explain how innovations in ophthalmology and in indirect ophthalmoscopy could reduce inequities in care. I think that's a big focus of mine. So for those of you, most everyone here knows what indirect ophthalmoscopy is. We all put on these headsets that have lights on them and make your patients blind and have a lot of pain and tearing. But basically all it is you have mirrors that shift your view coaxially with a condensing lens to view the retina. It's really useful in viewing the periphery of the retina, as Dr. Katz was joking. Maybe we'll eventually see the aura, but that is one of its main uses. But realistically, the last major innovation in indirect ophthalmoscopy was made by Dr. Shepens back in 1945. It's not really made a whole lot of changes. Like, we use pretty much the exact same thing. And Dr. Shepens actually was just going through wreckage from bombings in World War II to find equipment to build this, which was kind of cool. So the problem I find with indirect ophthalmoscopy is that as a trainee, right, it's hard to learn. it's very difficult to teach residents and trainees, you know, what they should be looking for, what to do to compensate for things when they go wrong. Because you just don't know. And a lot of the newer indirect headsets don't have a teaching mirror. So you can't even see what the resident or the medical student or the fellow is seeing when you're doing it. I know for retina fellows, one of the things that they run into is that if they're learning how to do cryo, you as the attending are just sort of like, well, hopefully they're getting. And so these headsets are expensive. You know, I know in the grand scheme of things in a healthcare institution like UK, these headsets aren't super expensive, but really they run $2,000 to $3,000. You have to have a power source. Sometimes they come with a battery, sometimes they don't. Sometimes the batteries stop working. Sometimes they break and we have to solder things to fix them. And they are a little bit bulky. You know, as residents, we're like carrying these around in the hospital, just like carrying them around, walking around, and sometimes they fall. And it's just, it's not, you know, it's not super ergonomic. And then I think the other issue that certainly we've run into is, you know, how do you monitor disease course? You know, we have fancy equipment at UK, but some other, you know, clinics don't, and you're relying on their examination skills and their ability to describe their exam findings to tell you how that patient was doing over the last several years. Or you have to learn how to draw fundus exams, and I don't know if I can do that. So digital indirect ophthalmoscopy has gotten a lot better over the last few decades. You know, it does make tracking a lot easier. You can, you know, take pictures and then track those over, you know, over serial exams. It can be made inexpensive. There are examples that exist today that with your smartphone or with, you know, certain equipment, you could do this. There are tabletop methods, you know, TopCons or, you know, your OCT machine or what have you, that you can use those optos for wide field imaging, but certain patients just aren't good candidates for that. They can't sit in the chair, they're bed bound, they're children, they just won't cooperate with you. Handheld methods that are bimanual, that require both your hands to coordinate, do have an additional learning curve, and I can certainly attest to that. You know, John Bader is extremely good at doing that on call. He can like hold his phone and like hold this and like get the patient in the axis and like get a perfect image every time. I cannot. And communication with other providers is still limited. A lot of these examples of digital indirect ophthalmoscopy require, you know, software. They have a computer, you have to hook it up, you have to somehow transfer it to your record system. And a lot of times when they send, you know, when you receive a patient that has exam findings and you want to look at the old pictures, they send it like fax to you, and it's all this like grainy black and white mess. Like you just like, this is the world we live in today. And so that's kind of what sparked my interest in trying to do something a little bit different. And this is some of the examples that exist today. Michael Ullman, when he was a resident at Georgetown, developed an iPhone application and then an Android application that lets you just use your phone. It has a focus knob, a light brightness knob, and you can take pictures of the fundus. You take a video and then you select a slide on that video frame that matches up with what you need to see, and you can send that, you know, via text message, add it to your record system, or what have you. Like I mentioned before, it does require a lot of hand-eye coordination that you don't necessarily have, or it takes time to get used to. Aaron Wang and David Guyton over at Hopkins, they developed this head-mounted indirect ophthalmoscope camera, which I think my solution is very similar to. And what they did is they took an iPhone, they basically 3D printed something that goes on another indirect headset, and added a little condensing lens here to focus on the iPhone screen. And it worked really similar to how our indirect headset works today. It's a custom application. It's not available, like you can't download it on the internet. And it needs a custom mounting solution, like they mentioned. You know, you have to 3D print something. And this is just a video of what that looks like. I don't know if the sound's gonna work, but.
The head-mounted binocular indirect ophthalmoscope has been an essential part of the retinal exam. Its greatest advantage is the ability to view the peripheral retina. However, Many ophthalmologists in the developing world cannot afford an indirect ophthalmoscope. We have developed an inexpensive indirect ophthalmoscope using standard headband with an attached plastic plate that securely holds both a close viewing lens and the smartphone. The plastic plate is easily 3D printable. The smartphone's built-in flash acts as a source of illumination. We have field tested this device and found it useful for recording fundus exams in the clinic, in the operating room, and at screening camps in underserved villages. This device allows for recording of high-quality videos of various retinal diseases. The familiar movements in performing the indirect ophthalmoscopic exam are all preserved with our device. We can mimic the results of a video-equipped indirect ophthalmoscope in the field at very low cost, while creating teaching opportunities for our residents.
And so I think that gives you a little bit of an idea of what we can do today. I mean, certainly that was like 5 years ago. That was like an iPhone 6 at that point. But you can see that that only had a monocular view. They mentioned recording, so you could send stuff to other providers, but you couldn't see what they were seeing in real time. And so hopefully my device or prototype today can sort of accomplish some of these tasks and provide solutions for some of those problems. So your phone, like your iPhone, right? Like you pull it out, it has 2 cameras on it now, and it has a light source on it, or some have 3 now, I guess. And you know, if you look at the other, like if you look at your indirect headset, it looks really similar to that, minus all the mirrors in the headset. And so that kind of gave us an idea of, well, what if we just like access both cameras at the same time and put them side by side? Would we be able to get a binocular view with stereoscopy? The problem, as you can see, is that the ultrawide camera is a lot wider of a field than the normal camera on the other side. And so then we had to think about, well, how are we going to fix that? And honestly, it was a pretty simple solution. We just zoomed in. We just like zoomed in on one of the cameras, and that helped a lot. It was still a little bit too wide of a field of view for both cameras, and so we just added some magnifying lenses to a case. And that improved the view a little bit more. And then all we had to do then was stick it into a commercial headset that you can buy on Amazon today, and gives you, you know, stereoscopy and a pretty coaxial light source to do your exams. And so this is just a short demonstration. I'd like to thank Dr. Blosser for volunteering his examination skills, but that's essentially it. Like that's all the equipment we needed. You just keep your normal indirect lens handy, and you can do your exams. And this was his first time ever using it, and he picked up on how to use it pretty quickly. There was no real learning curve involved. As you're looking at this video, certainly besides my photosensitivity, you'll notice a couple of issues. You know, glare is one of those issues. The field of view isn't quite realistic. There's definitely a lack of resolution on the left-hand side compared to the other side. There are other issues too, but those are some of the like main limitations that we're sort of finding with this, and I'll talk about those in more detail. There's a knob here for the light brightness that you can modify, and then this changes the focus if your focus is not already in focus. We've added a couple of other toggles here that unfortunately I don't have a demonstration for today, but you can take a picture, like a quick snapshot. You can switch to red free mode, and you can even have voice commands to change certain settings. Then you'll probably see me at the end like cringing in pain.
It works here.
Yeah. Luckily, I'm not cupped. And so I do think there are a couple of advantages to doing something like this. The cost is certainly a big win, I feel like, in doing this. Right, your bill of materials is the cost of your phone that you probably already own, the cost of a lens. While the Voke lenses are expensive, there are other lenses on the market that you can purchase. And you can even 3D print your own lenses now. So Shane, if you have the right filaments, maybe we can do that. The ability to record and live stream is really interesting. And I think it lends itself to being able to consult or communicate with other providers quickly and easily in a way that is intuitive for people because they're used to using their phone to do these things already. And I think the other thing this lends itself to is by using a device that already has a processor and a lot of smarts in it, we can do really interesting things with the images in real time. So we can do image processing, we can enhance the images we're seeing, we can go into red free mode, we can actually use some near infrared wavelengths and do some machine learning on the fly. Apple especially makes this really useful. I'm not sponsored by them, but they have a neural engine built into their phones. And I think the interesting part is it makes inference and machine learning a lot easier and could kind of open up a whole new world for doing some diagnoses on the fly. There are limitations, as you saw in the video. Resolution is a big issue. And I think that is mainly because these iPhones were not meant to take like really high resolution video. They're meant to make videos that are sent for social media, right? They weren't built to do coaxial illumination. In fact, they're probably made to reduce coaxial illumination as much as possible to remove red eye from photos. The performance, I think, is actually fairly good, but we would probably benefit from more performance. And I certainly, you know, this is where technology is progressing at such a rapid pace. By next year, we may have a better device for you all to try out. The glare was a big issue. As you could see, you know, there are some tweaks that we can make to that. And I think the light source is going to be really important in reducing glare. And then comfort, I don't know. I mean, Peter, what did you think? Did you feel like it was uncomfortable or
Felt fine.
felt fine?
A little disoriented. But not
Yeah.
really.
Because your field of view is not quite exactly what you would find in an indirect headset. The reason for that was twofold. One is we wanted to give you a more magnified view, and the second reason was that the resolution was so low that you needed to magnify that view. And so these are some kind of examples of where I see this being used in underserved areas where you don't have access to digital equipment to take pictures and photos, or you just don't have an indirect headset lying around, or you know, can't afford one. Being able to teach indirect ophthalmoscopy is I think a big use case for this. For trainees, you could be watching how a trainee is doing their exam in real time and provide real-time feedback on how to improve their examination skills. Recording examination findings and live streaming them with other providers are going to be, I think, a big use case for this type of device. This is some future work. I think we want to develop this for other platforms. I have a prototype application for Android in the works. I just don't have a phone with multiple cameras to really test that with for Android phones. But there are Android phones out there that have 50 megapixel cameras on the back compared to the 12 megapixels on your iPhone. I think that's going to be really interesting to see. They have higher resolution screens. Wanting to try better cameras and lens combinations to improve your field of view, to improve the resolution, I think are going to be other interesting parts of this. And then adding different LEDs to this, I think that's going to be really interesting to see. If we can make a better coaxial light source that's just plugs into your phone, or use different types of wavelengths. Your iPhone actually can see in the near infrared wavelength range. And so that's just a demonstration of like what sort of things you could possibly find at different wavelengths of illumination. And so maybe we could find different choroidal pathology that you just wouldn't be able to see super well in a normal color video. And then testing the usability of this device and testing it with real pathology instead of just like my healthy N of one eye. And that IRB is in the works already. And so that's it. I wanted to acknowledge Dr. Blosser for lending his time on a busy clinic day, and then Dr. West for letting me use some of her equipment as well, and for making this project a success. Yeah.
Is presbyopia an issue?
No, so the condensing lens that, well, I don't know, maybe, I guess I don't know. I don't have presbyopia. But I don't think so. So the condensing lens that's in the VR headset. So these lenses over here inside of this are basically 20 diopter lenses actually, but they'll let you zoom in to view the phone. And a lot of these commercial headsets that you can buy on Amazon actually can shift how far away the phone is from those lenses. So if you do have an issue with focus, that is pretty easily managed. Other questions?
So, is there any post video or phone processing that you can do to get rid of some of the glare?
Yeah, so I looked into some of those methods, and I think honestly, one of the things that we can do without processing will be just using a different type of light source, or even shifting the light source up a little bit to make it more coaxial. There are phones that have more of a coaxial light source as well. So like the iPhone 10 has a much more coaxial light source, and so when we tested this with like Nikki's phone, for example, a lot of that glare was actually reduced.
So when you fish, you use polarized lenses. Why couldn't you polarize the lens?
You could, right? So like by adding those lenses on the back, you could polarize them. I don't think that's a bad idea at all.
You approached Apple about having a laser.
You know, Dr. Moore had the same question.
This may be silly, but will this vary based upon the iPhone model that comes out and the number of cameras?
Yes and no. So yes, it can, because those model phones may have different focal lengths. And so you'll have to adjust the zoom on those camera lenses. So like with the iPhone 10 has a telephoto lens and a wide angle lens instead of an ultra wide and wide. And so in that case, right, you don't want to zoom in the telephoto lens more, you want to zoom in the wide more. That's an easy fix in code, right? I can ask the phone, I can say, what phone are you? And if it says an iPhone 10, then I can adjust the zooms appropriately. And so the question or limitation down the road is, what happens if Apple stops making, or some, different phone manufacturers stop making phones with multiple cameras that are side by side in a horizontal fashion? What do you do then? I don't have a great answer for that, honestly. But yeah, good question. Yeah, so excluding the price of the phone, excluding the price of the lens. I mean, we can include the cost of the lens. Let's just say the cost of the lens is about $30, right? If you're going for like the lowest cost material. You can make this probably as cheap as $50, probably. That'd be
Minus the smartphone.
yeah. So I don't know yet. I was thinking about that. And I was just wondering, like, well, if it's off a little bit, right? Is that a big deal? Or did Apple already shift it up a little bit to begin with?
Because a lot of the Android phones, the cameras are vertical.
No, that's how it is here, right? These are vertical, but if you're looking like that, it's then side by side. So that's okay from that regards. All right. Well, thank you all.
Morning, everyone. Thank you for being here. So I wanted to quickly introduce the person introducing the next award, if that makes any sense. Quickly, also just to thank you to Maddie and Angela for all the work they've done just making this happen. It's always such a nice thing to have this. It's well organized and it's great to be back in person. Like Peter was saying, this is as large of a group that we've had gather, I think, since before the pandemic. So we're going to move on from live tweeting your indirect photos while downloading a podcast to a simpler time. And many of you may not be aware of who Dr. Keeler is as we are transitioning to younger generations. So Dr. Richard Keeler is an emeritus faculty in our department. He was a long time incredible teacher of ocular pathology for our residents. I think those of you that had a chance to work with him are realizing what we've lost. Before that, though, he was an active clinical member of our faculty. Started very early on in the founding of this department. So we are here because of him, at least in part. Another person that is played an instrumental role in this department is the person whom this award is named after. So you get a chance to meet the lineage of that. And so without further ado, Dr. Keeler.
Thanks, Dan. Most of you here have no idea who I am. So we'll just say that I've been around here for a long time. But this award, this teaching award, was established to honor Jonathan Wirtschafter, who was the first chairman of this department. Not particularly because he was the first chairman, but his ability to teach. And that's how the award is named. So the award is given to one of the residents. We know that residents get a lot of their information from the faculty, but there's also significant teaching that goes on between the residents. So this award is given annually to one resident who is voted on by his peers, not the faculty, but the other residents, in terms of who was felt to be the best resident teacher for the year. So to present this award, we have one of Jonathan Wirtschafter's son, Rabbi David Wirtschafter. He moved back here several years ago, and it's great to have him back. And so he will present the award. And say that he is an absolute carbon copy of his father.
Thank you, Dr. Keeler. It's wonderful to be back with all of you. You know, I look forward to this day every year. It's one of the highlights of my year. I want to give a shout out, as I always do at these gatherings, to Doctors Katz and Katz for patiently being the ophthalmologist to the Wirtschafter Sippy family. They have now seen all three of us at their different offices. And this prescription is still holding up really well, Doug, so thank you. And I've now had the good fortune to do the bar bat mitzvah for all three of the Katz children. And I was teasing Rosie that if she thinks it's difficult being the child of two ophthalmologists. Well, I can empathize at least 50% being the child of one. So as I look around this room, it's really powerful today. The two posters or two of these posters in the back would have meant a great deal to my dad. I look at the county map of Kentucky and the wonderful image of where the wild things are by the Jewish American artist and illustrator Maurice Sendak. And Dad loved reading Maurice Sendak stories to his children and later to his grandchildren. Unfortunately, ALS stepped in and deprived him of the chance to share those books with the next generation. But looking at the monsters from where the wild things are, with ophthalmological equipment on their faces, that would have given Dad a big laugh. So kudos to whoever came up with that one, and
I'd like to find out a way that I can get that poster replicated for my office. I'm going to send a picture of that to my mom when I'm done here. I also want to comment on the glaucoma poster, and this is a little bit of asking for your doctor-client patient confidentiality. So what happens at the William T. Young Library stays in the William T. Young Library. Okay, so I'll tell you this story about my college years and my dad. So I was a freshman at the University of Minnesota, and my sister was a senior in high school. And it was a few moments before dinner, and we were watching PBS, and there was a piece on glaucoma research and the efficacy of marijuana in treating glaucoma. And being Jewish, I get to make Jewish jokes. So there's this Jewish academic sitting there, and he's a patient in this study, and he's reading this encyclopedic, thick, dense thing on the efficacy of marijuana on glaucoma with a 10-inch Jew fro and smoking a 5-inch spleef. And my sister and I turned to my father and say, "Dad, could marijuana really help to treat glaucoma?" And he says, "Well, you would have to be stoned constantly." And we burst out laughing, like, "Oh, like this is the problem." But you didn't hear that from me, and what is said at the William T. Young Library stays in the William T. Young Library. On a more serious note, I wanted to share with you a thought from our daily prayer book. I want to talk about sight a little bit. This prayer that we say includes the following words. We pray that we might know before whom we stand, the power whose gift is life, who quickens those who have forgotten how to live. We pray for the winds to disperse the choking air of sadness, for cleansing rains to make parched hopes flower, and to give all of us strength to rise up toward the sun. We pray for love to encompass us for no other reason, save that we are human, for love through which we may all blossom into persons who have gained power over our own lives. We pray to stand upright, we've fallen, to be healed, we sufferers. We pray to break the bonds that keep us from the world of beauty. And I want you to particularly pay attention to these words. We pray for opened eyes, we who are blind to our own authentic selves. We pray that we may walk in the garden of a purposeful life, our own powers in touch with the power of the world. Praise be the God whose gift is life, whose cleansing rains let parched men and women flower towards the sun. I know that this is a science event and not a political event, but I want to tell you something about my father's legacy. He was proud, among other things, of being one of the first people to successfully recruit people of color into ophthalmology. It wasn't easy to do, and the work of diversity continued to be an important area for him throughout his career, whether it was recruiting women, LGBTQ, people from around the world, and whether or not there was a special preference for Jewish residents and fellows and interns, who can really say? And after I fell in love with a beautiful woman from of Indian extraction, did the number of South Asian recruits grow up? Well, we can wonder about that one too. But diversity mattered very, very much to Dad. And he also cared about justice. And he was not afraid to put his reputation on the line as a physician and as an academic to speak up for what was right. And that included here at Lexington during the height of the Vietnam War, where after the terrible shooting at Kent State, my father sat down with the president of the medical school and said, this is signed letter of resignation. If one student is shot and killed at Vietnam protests here, I'm going to put a date on it. As you think about the crisis in our country over reproductive rights and over gun violence, I ask you to do no more and no less than what my father was ready to do when it came to diversity and when it came to having a just society and a true democracy. I don't want to make this an over political event. I don't want to make it a partisan event. But we cannot have autonomy and we cannot have equality in our country when 50% of the people are told that they don't have bodily autonomy because they have a uterus. It cannot work this way. It cannot function this way. And I'm sick and tired of the gun lobby telling physicians whose hospitals are being shot up and whose clinics are being attacked, and some of whom are themselves the victims of gun violence, to stay in your lane. As the physician who is himself a victim of gun violence retorted to them, this is my lane. Gun violence is your lane as physicians, as parents, as children, as human beings. Reproductive rights is your lane as physicians, as parents, as children, and as human beings. And don't let anybody tell you differently. I want to thank you as physicians for the wonderful work that you do, for getting us through COVID, and for keeping our eyes open. I want to close by bringing up this year's award winner. I sometimes like to joke in my family that Tubby Smith's career mirrored that of my father. He went from the University of Kentucky to the University of Minnesota. And so it's a particular honor since after being here from birth through first grade, having been raised in Minnesota from second grade through my freshman year in college, and my dad being at the University of Minnesota from the day we left here until the day he died. And we joke in Minnesota that rather than our license plate saying land of 10,000 lakes, it ought to be the land of 100,000 Petersons. And so it's a particular pleasure as a Kentuckian and a Minnesotan to call forward the winner of this year's Wirtschafter Award, Dr. Eric Peterson. Here you go, here, Dr. Peterson. I get to do that Cohen brothers take on a Minnesota accent because I'm from Minnesota. Congratulations on behalf of the Wirtschafter family.
Thank you.
Can I take a picture of you guys?
I don't like ophthalmologists taller than me. This is really weird.
Utah.
Utah.
Yep. The ones that didn't go to Minnesota came to Southern Utah.
Thank you all very much, and have a lovely, lovely summer. And congratulations, Dr. Peterson. Thank you, Dr. Keeler. Take care, everybody.
All right. So congratulations. Next, we're honored to have our talk by our guest speaker, Dr. Nathan Steinle, and some of you might know who he is. He's one of our own UK alumnus, graduating the class of 2009 as chief resident, and he's originally from South Dakota. He completed his surgical retina fellowship at the Cole Eye Institute in Cleveland, then flew west to California, where he joined a very successful practice. And now he's here today. And he has quite the decorated CV, and I could go on and on about his accomplishments, but for those of you who know me, I like to pull interesting facts and share them about people, especially guest speakers. So I asked Dr. Stanley a few questions. I asked him, number one, what's the coolest place you've been to? And he said, Dubai and Abu Dhabi. But if Dr. Timley can hear him right now, his answer is Dublin. Number two, what is something on your bucket list? And he said to complete a full Ironman triathlon, which I do believe. And number three, most importantly, why do you love UK? And Dr. Stanley is a diehard UK basketball fan, and I have to take his exact quotes to describe that. So sorry if I embarrass you. But he said he's the type who takes it personally when a recruit doesn't choose the Cats. He thinks UK should win every game and yells "Go Cats" whenever he sees someone wearing a UK t-shirt. And he geeks out when he sees Malik Monk walking around in LA. And finally, he's really glad that Coach K retired. So please welcome Dr. Nathan Steinman.
Switch it over to that.
Hey, Park.
Yeah. So I got it right there, so you go to HDMI. Yeah. So I got the HDMI plugged in right here.
And then I think we just
Switch it there. Oh, that's awesome. Great. Oh, that's perfect. Perfect. Awesome. So, hey guys, I'm Nathan Steinley, and I'll steal a line from Dr. Keeler. Most of you don't know who I am anymore, which is kind of amazing. Good to see you again, by the way. I'll share a couple of stories while I'm here. It's just awesome to see some familiar faces. So I was here 2005 to 2009. I'll give you a little timeline of what that means and what kind of time frame UK looked like at the time. Dr. Keeler, seeing you, it just reminds me of a story. One of my most exposed moments in my life was I got a talk accepted to the Ophthalmic Pathology Conference, the national meeting, right? So you're going to go and speak in front of a bunch of ophthalmic pathologists and talk about being exposed, right? We all know a little bit about little cells, but these guys know their stuff. And so I was presenting a case of squamous cell carcinoma metastatic to the retina, very rare. And I went through my talk, and it's full of people, 100 people, all pathologists there. And I'm just dreading the question and answer because they're going to pick me down on slides and stains, and I was just going to be exposed. And just at the moment the Q&A started, Jerry Shields, who was in the very front row, he sits on this little stool. He fell off the stool, and he's like a legend. So there's this big commotion to help Jerry back up on the stool. And by the time they get him back up on the stool, my Q&A was over. And so I didn't get a single question. So Jerry always gets a beer from me every time I see him. I love that story. So I'm in California now. I had clinic yesterday till 6:30 at night. I got to LA at midnight last night. Red eye here, and I'm really excited to be here. It's such an honor to be here, and I thank you so much for the invitation. And hopefully, I'm going to give you two different talks. The first one's going to be an academic talk to show you that what you can do when you're sitting in that same seat, what you can do with your career in the next 10 years. And the second talk I'll give later is more of a personal talk about how you can get there. All right. So first off, my group here, I'll show you this list. We have 12 retina specialists. We're in California. We're based in Santa Barbara, and we cover most of the area from northern LA up the coast, all the way up to almost Monterey. And we cover the Inland Valley too, Bakersfield, Visalia, Palmdale. So we cover about 400 geographic miles. Who am I? Why the heck am I here? So I'm a no one. I shouldn't be here, right? I was born and raised in rural South Dakota. The only cool thing about me, I was born in Sturgis, South Dakota, right? And it's a tiny little town, but it's where the motorcycles are at, right? So 1 week out of the year, we have a town of about 400,000 to 500,000 people come, right? The rest of the time, it's about a town of about 5,000 people. So very small town America, but gave me a good feel for the world 1 week out of the year. I did everything in South Dakota, high school, undergrad, med school, and I was always at the top. And I was just lucky to be smart and have a good family. And then I got the best opportunity ever, and that was to come here from 2005 to 2009. And it was before you actually had to do your surgical intern year here. Like I think now it's part of the program, but you have to do the first, yeah. So then I actually wanted to come here. So it was me, Peter Timoney, Carrie Pate, and I think we just formed an awesome bond. It was back when there's only 3 residents. Julie Stevens was the program director before Dr. Kapoor. And so we did a brutal surgical year. We did, neurosurgery, we did plastic surgery. I remember doing like hand call, face call. We did vascular surgery, but it was really fun bonding time with those guys. And then Peter's obviously still here. Is Higgins here right now? Yeah, Higgins was my junior. Yeah, Melanie was my junior too. So it's good to see you, bud. So then a resident here from 2006 to 2009. And then I did my clinical fellowship then at the Cleveland Clinic from 2009 to 2011 with Dan Martin, Peter Kaiser, John Sears, Rishi Singh. And it was the height of the CAT trial. So it was kind of fun being there when I'd be in the clinic with Dan Martin, he'd get pulled aside by someone from the New York Times or from the LA Post, and they want to get him some quotes about the CAT trial. Then I went out to California. I've been in California now for 10 years. This is 2011 in private practice. And then in 2020, as a full partner, we actually sold PE, and I'm in Retina Consultants America, which is the largest retina group in the world. We have 170 retina specialists now together, and including about 15 states. So when I was here, what the heck time was it? It was 2005 to 2009. I had 2 years of Tubby while I was here, and I had 2 years of Billy while I was here. That's the time frame I was here. So the day I left, I remember Higgins, we were at the VA, and it was the day that John Calipari had his press conference. He was coming here from Memphis. We were all watching, excited to have him come. So the day I left, unfortunately, that's when like DeMarcus Cousins came, John Wall came, Eric Bledsoe, all the good players came after I left. Just to show you how long ago I was here, look at Jody Meeks' shorts, man. No one wears shorts like that. Right? It's amazing. And I got to see a game at Memorial Coliseum where the Cats play. And they were so bad that year, they actually got into NIT. And I think it was the last time the Cats played at NIT at the Memorial Coliseum. And the crowd was chanting for Jody Meeks to stay one more year, right? One more year eligibility. And so they were saying just as loud as they could, Jody Meeks, one more year, one more year. But Billy was there. And at the same time, there's a second part of the crowd that started chanting, not you, Billy, not you. Yes. All right. So I'm going to tell you a little bit of story. So this is going to be a little bit of clinical data, but I know not everyone here is clinical scientists. So just follow me. Don't follow the slides. I'm going to tell you about the story of pegcetacoplan. Has anyone heard of this molecule at all? Anyone at all? This is going to be hopefully $1 billion drug. And it was developed just right down the street. $1 billion drug right down the street. Story of pegcetacoplan. So the only relevant financial disclosure I have is it's a company called Apellis, and I'm a consultant for them. I've been working with them for years. I'm actually kind of proud of this slide. This is my overall financial disclosures. I work for a ton of different companies. So there's all my consulting gigs, independent research, speaker bureaus, and then I'm an owner in a couple different companies as well. But the only relevant one here is Apellis. So a case, you guys all see patients. You see lots of patients. I remember being here, and the digs have gotten a lot nicer, by the way. This is a beautiful room. We used to be in the other building, right? And I remember walking in and like the trifecta on Fridays. Conklin would have a clinic, and then it would be Pearson would have a clinic, and then Julia Stevens would have a clinic all at the same time. And you walk in that main waiting room, it'd be like walking into the DMV, right? There'd be a million people everywhere, right? Like cross-eyed kids that people couldn't see, and then the people who complain the most are the Conklin refractive patients, right? You know, who are 20/20. It's just so frustrating, right? The other good Billy Gillespie story is that when he came here, Gary Wartz, who was my senior, he had the opportunity to refract him. So when Billy came here, he had to get contacts, right? This is a coach's basketball team, big deal. And so Gary refracted him, and then like he kind of over-minused him. And so like a week later, Billy calls him up and says, Gary, you know, this is great contacts, all, but I really can't see. And so I blame some of our recruiting on Gary Wartz. That's what I really do. All right, so this is a pretty simple case. And I always like simple cases just to drive home a point. This is a patient we could all see tomorrow or next week. 83-year-old female. She's 20/25 and 20/30, but she's unhappy. She cannot read, right? She cannot read, she cannot read, she cannot read. And then, okay, 83-year-old female, she can't read. Pretty crummy picture, but you look at her fundus, she's like, don't look that bad. But what I always do in these patients, and what you guys probably always do, is you get fundus autofluorescence. And I've just been a huge believer now of fundus autofluorescence. It's one of the few images that everyone can do. Ophthalmologists, optometrists, opticians, the janitor can do this test, right? And it gives you functional data. It gives you functional data. You can actually look to see where cells are actually dying. You can see where the hyperautofluorescence is. You can see where apoptosis is going to happen. You can see why this lady can't see. You can see why she can't read. She's very frustrated with her vision, even though clinically she's 20/25, 20/30 on Snellen vision. That's a frustrated patient. How about the other eye? Well, let's look at OCT first. Real classic looking OCT here. You can see the choroid capillaris. You can see a preserved central island of photoreceptors. That's why she tests 20/25, 20/30 on Snellen. We all know that Snellen is not everything for visual functioning, especially in patients with geographic atrophy. And then the left eye, again, she says, I just can't see. Doesn't look that bad there. But the fundus autofluorescence, this looks like Pac-Man, right? It's going to come in, it's going to gobble up that fovea pretty quick. You can see the areas of autofluorescence at the edges there too. Again, you can see that central island of preserved photoreceptors. Otherwise, it almost looks like a plaquenil patient with that paracentral geographic atrophy. So let's get back to my story. Story of pegcetacoplan. What is this molecule? So this is what it is. And I remember being here when Jay Ambati was here, and he would just grill us on structures and things. And he taught me so much. And I'm so happy to have that knowledge. So this is about 40 kilodaltons. So it's a little bit under the size of Lucentis. It's a cyclitic peptide, and it blocks complement. It blocks complement. Why do you care about this? Why does anyone care about this? Well, there's a company right down the road, Apellis. Anyone heard of Apellis? It's a Louisville-based company, and now it's moved to Boston, right? You can buy this. This is just from yesterday. This is from NASDAQ. You can buy it on the stock exchange, $41 a share. And it is actually a pharmaceutical company, and they came up with the C3 inhibitor, a complement inhibitor. And what does that even mean? Well, I'll show you here in a second. This is their pipeline, right? So busy slide, you can't see in the back, but just know that they're taking this complement inhibitor and they're trying it on all these different diseases, including they've already got an approval of one. If you look at this top one here, this is one for PNH, paroxysmal nocturnal hemoglobinuria, one of those board questions, right? And so it's already approved on the market, FDA approved for PNH, but they're also trying it in a whole bunch of other hemolytic anemias, including things like CAD, some of the glomerulonephritis. In ophthalmology, they have actually completed now phase 3 clinical trials. And they've submitted their NDA, their new drug application. So I'll show you that data in just a second. They're looking at neurology and they're looking at other targets as well. All right, so let's bring it back to home here. So this is a company called Apellis. This is the molecule that's on label now. It's a C3 inhibitor. It's works for proximal nocturnal hemoglobinuria, and you can dose patients with it today. How does it work and why do we care about it for ophthalmology? You remember these slides, and I'll lose you quick if I spend too much time on it, but just know that complement is a big deal. It's an inflammatory marker that we all have in our body, and it's very, very significantly involved in atrophy and in specifically drusen formation for dry AMD. All right, so what the heck is that complement cascade? You remember these questions? There's 3 different forms. There's the lectin arm, there's a classical form, there's an alternative form, and they all converge on C3. They all converge on C3, and there's a whole complement cascade from there. So if you're going to try to come up with a molecule to try and block somewhere, you probably want to aim for C3, and that's where this pegcetacoplan blocks. There's other molecules that have been tried, such as C5 inhibitors. There is a factor D inhibitor. A whole bunch of different inhibitors are being looked at along this cascade. So another molecule that's on the market right now, this one right here, eculizumab, it's the most expensive drug in the world. It's made by Alexion. It's Solaris as the brand name. It costs $500,000 a year. It's also to treat very rare hemolytic anemias. And so $500,000 a year. So it's very expensive. And when they came up with the drug pricing, Alexion got a lot of flack from the press, of course. They tried that in ophthalmology. It says, okay, well, let's hang that systemically and let's try that for GA. And it's really hard to get a systemic drug into the eye. And that's what they found from the study. Probably would work if you gave it high enough doses, but it was hard at the clinical doses they have right now to penetrate the eye. So this one did not work as far as a systemic therapy for GA. Lampalizumab, you guys remember these trials? These are the huge trials, Chroma and Spectre from Genentech. Billion-dollar shots on goal, billion-dollar shots on goal for geographic atrophy, looking at complement factor D. Turned out to be the biggest natural history study in the world, right? Unfortunately, 1,800 patients in Spectre and Chroma looking at geographic atrophy, and unfortunately, basically had no effect whatsoever. And if you went back and looked at why they did this study, Chroma and Spectre, they did it on Mahalo's data, which is their phase 2 data, and people could pick apart Mahalo every which way. So it's probably studies that shouldn't even been done, but they did it, and it showed that unfortunately factor D inhibition did not work for geographic atrophy. All right, let's move to the next one. So the next big trials, and I've had lots and lots of patients in these trials, were Oaks and Derby. And the cool thing about Apellis, because it was a company based in Louisville, all their trials are equestrian based. It's pretty cool. They had Philly, they had Oaks, they had Derby, they have Paddock, they have Gale, they have, what are the other ones they have? Anyone that has a horse theme, just know that's an Apellis trial, which is cool. It's great branding, right? So Oaks and Derby, huge phase 3 trials for geographic atrophy. These are not easy trials to pull off. 600 patients in Derby, 600 patients in Oaks. That's 1,200 clinical patients going across the entire world, followed for 1 year and actually all the way out to 3 years in the extension study. Here is the trial design for Oaks and Derby. They were very identical, 2 different trials, Oaks and Derby. And I always like to ask this question because I didn't know this, but do you know why I always do 2 trials? Why is there Rise and Ride? Why is there, View 1, View 2? Why is there, what's the most recent ones? Let's say Lucerne and Tenaya. Why is there Rhine and the first map trials. There's always two. The reason why is the FDA requires a confirmatory trial, right? So not just one, but two. You need two trials to get FDA approved. So Oaks and Derby, two huge trials, 600 patients in each, looking at geographic atrophy. This is the way that the molecule is dosed. It is dosed either monthly, every other month, versus sham, randomized 2 to 2 to 1 to 1, overall 1,200 patients. The primary endpoint, geographic atrophy on fundus solid fluorescence at 1 year. Patients are followed out to 2 years, and there's actually a 3-year extension trial, GALE, right? And so we've now reached the primary endpoint, and we're into the second part. We've actually, the 18-month data has now been released, and they're following these patients out to 24 months, which would be about 6 months to get a little bit more data. So I'll talk you through this and why this is such an important molecule. So this is pretty cool. So this is last year at ASRS. This is as big as it gets. It's what's an honor. I got to present the phase 3 data for Apellis. This is, for a disease we don't have any treatment for, right? And this would be the very first positive phase 3 trials for dry AMD ever. And so I got to present the data at ASRS, which is really exciting. Also super nerve-wracking. About 1,000 people in the audience, and there's also then tons of investors on every call listening to you, and they want to listen to every word you say. If you say clinically significant versus clinically meaningful, and they want to follow each individual detail, plus there's competitive companies that want to ask you a lot of questions to try and take you down as well. So I've never been more prepped for a talk than I was for this one last year at ASRS on the main stage. And it was funny because I gave the efficacy data, and then Dave Boyer out of LA gave the safety data. And I really thought that Dave was going to get all the questions, right? Everyone wants to know about safety. Dave got like one question, and all the rest of the questions were handed my way. And thankfully, I was well prepped by the team at Apellis. But it's pretty cool. Here I'm a little kid from South Dakota presenting phase 3 data at the major conference last year, right? For a drug that's hopefully going to revolutionize the way we treat geographic atrophy. All right, so let's talk you through it. So back to this molecule, this pegcetacoplan. What the heck does it do? It's APL2 is its generic name, and it binds at C3. And by binding C3, doesn't take a genius to realize you're going to knock out the entire downstream cascade. Lectin, classic, alternative, you knock out all that complement cascade downstream. Phase 2 was Philly. It showed a 29% reduction with monthly dosing and 20% reduction with every other month dosing at the 1-year mark. Based on that, Oaks and Derby were allowed to proceed. And this is the very first phase 3 trial for geographic atrophy that showed positive significance. And this is the very first slide that ever showed significance for a dry AMD trial at phase 3 data. So here they are. This is pretty cool. This is for Oaks, and it showed significance, a 22% reduction in GA growth at 1 year versus sham. And the every other month dosing was in at 16% reduction. So there's dose-dependent reduction in GA progression at 1 year. Interestingly, Derby just barely missed its primary endpoint. So you have one positive arm, and Derby was just barely negative. And how negative was it? The p-value is 0.0528. So it just barely missed. The every other month dosing is right in there as well, 11% reduction. But they had a planned combined analysis of both Derby and Oaks. And the combined analysis showed overall a 17% reduction in GA growth at 1 year versus sham, and 14% reduction at every other month dosing. And so where does this work the best? It actually works the best in pre-specified extrafoveal lesions, in lesions that are not involving the fovea. You think about it, right? Patients with GA either have fovea involved or extrafovea involved. And you'd hope it would work everywhere, but where it works best in those patients who have extrafoveal lesions. And these patients had a 26% reduction versus those who got sham, and a 23% reduction those who got every other month dosing. And so what was their definition of extrafoveal? It was actually a perfect definition. It was greater than 0.0 millimeters from the foveal center. So if that geographic atrophy hit the very center part of that subfield, it was called fovea involving. If it was anything outside of 0.0 millimeters, not 0.01, but 0.0 millimeters from the foveal center, was called extrafoveal. And that's good for us to know. So for those patients, like I showed you at the beginning there, where they don't quite have fovea involvement, but they have really, threatening fovea involvement, this is probably the ideal patient for this pegcetacoplan. All right, what are the side effects? Everything's got side effects. This is an injection in the eye, right? Every time you do an injection in the eye, you're gonna have side effects. One of the interesting things that came up in Philly was exudation. Patients would get tipped over from dry to wet. That happens sometimes, right? Patients with dry tip to wet, but it seemed to be dose dependent in Philly. Those patients who got monthly dosing had a higher rate of conversion to CMBM. Those who got every other month dosing had a little bit lower rate of conversion to wet AMD. And those who had sham injections also had conversion to wet AMD, but at a much lower rate. So there's two different ways to look at that. One is very interesting in that a drug for dry AMD would have conversion to wet AMD, right? So one way to look at it is at least you're having some kind of biologic effect. And if you talk to the big committees at Apellis, they were actually somewhat positively affected by this data. They actually kind of liked the fact there was some exudation, because at least it showed this was not going to be a molecule like lampalizumab that basically had no effect on geographic atrophy, had no really effect on the macula itself. And so at least there's some biologic activity happening here. What they did in Philly, though, and that's the phase 2 trials, is they based it on investigator discretion. So the investigators determined if there was conversion to wet AMD. You guys know these patients with dry AMD, these OCTs are hard to read. And so sometimes patients with little cystic changes would be called wet. Patients with these like nebulous changes on FA would be called wet. And there was no OCTA confirmation in phase 2. So in phase 3, Oaks and Derby, Apellis got really smart and they said, okay, everyone's gonna be looking at this conversion to wet AMD. We don't want patients to convert to wet AMD. If they're going to convert to wet AMD, we want to make sure they actually did convert to wet AMD, if they're going to be classified that. So in the Oaks and Derby trials, they had a reading center confirmation of patients if they converted to wet AMD. So if a patient comes in, they're getting pegcetacoplan, month 6, month 7 goes by, it looks like they converted to wet AMD. It wasn't at the investigator discretion. It was actually at the discretion of the reading center, which is much more objective rather than subjective. They do an FA, they do OCT, and they actually do OCTA confirmation that these patients would actually truly have exudation. And what they find in Oaks and Derby, they actually did find again a dose-dependent increase in conversion to wet AMD. It was in the order of 6% in Derby, 5% Oaks, in pegcetacoplan monthly, and pegcetacoplan every other month was about 3 or 4%, and in sham pooled it was 3 and 1% at the end of 1 year. So, you know, there's a decent number of patients that converted to wet AMD, even in the sham pool. It seemed to be about double those who got this molecule. And those patients were actually left in the study and they were actually treated with standard care anti-VEGF therapy in addition to pegcetacoplan for dry AMD. All right, so pretty cool. So if you look at fellow eyes, you say, okay, if you go back and look at these data, right? So this is pretty cool stuff. So this is the very first time, again, that we ever had positive phase 3 data for geographic atrophy, right? And so, but this is against the sham pool. These are patients that were compared against a pool of sham patients, right? Well, what if you look at the internal patient? What if you look at the internal control? And so we went back and looked at lesion growth within the same patient. So if they're getting pegcetacoplan in one eye and they were following the other eye, how'd the other eye do? That seemed like a really good internal control. It wasn't against the sham pool patients. It was actually just an internal control. So we went back and looked at patients that would be eligible for Oaks and Derby in both eyes. And we said, okay, one eye went into Oaks and Derby. The other eye was outside of Oaks and Derby. How did they compare over time, right? How did they do over time? It seemed like a really good control to look at. Well, first off, you want to look at the sham patients. So if you look at the sham patients across Oaks, Derby, and Philly, this is what you expect. You expect the sham eye and the fellow eye to behave the same because neither one eye got treatment. They got sham in the study and they got no treatment in the other eye. And across Oaks, Derby, and Philly, there was no parsing of the data. There was no diversion of the curves. So the growth curves across all 3 trials are the exact same. But here's where it gets really cool. And this is hopefully where we're going to head by the end of the year, maybe early next year for this molecule, is that when you start to look at patients who got every other month dosing of pegcetacoplan, you start to see diversion of curves. In Oaks, Derby, and Philly, the fellow eye that did not get pegcetacoplan had a much higher rate of progression of GA versus those eyes that were in the trial. Okay, that's every other month dosing. How about monthly dosing? There's even further diversion of curves or separation of curves over time. So this is a beautiful internal control where you're looking at one eye that got treatment, one eye did not get treatment, but both eyes met criteria for Oaks and Derby. And how did they do over time? Well, the eye that got treatment had a statistically significant, although I have to call it clinically meaningful, result in both Oaks, Derby, and Philly across the board with this separation curve. Never seen this before. This is pretty revolutionary for retina. All right, so some conclusions. Very wordy slide, but I'll talk you through this here. In general, Oaks was an absolute superstar home run, knocked it out of the park. Was a great result for Apellis. Derby was kind of a mixed thing. It kind of made it, kind of didn't make it. It just missed a primary endpoint by that 0.0528, and statistically significant was 0.050. When they did a combined analysis of Oaks and Derby, it was highly statistically significant. And overall, they've had 1,500 patients, Oaks, Derby, and Philly, get this peg open and show this reduction in GA over time. And this is pretty interesting. They just filed their NDA, their new drug application, this month. And so now the waiting game begins. They had already talked to the FDA, and it's been really interesting. I'm on the data safety monitoring committee for Apellis, and it's been really interesting. One of our main questions was whether or not they would actually include the Philly data in their NDA evaluation. And the answer was, yeah. I didn't know this, but when we actually talked to the FDA, they actually do not actually, this is the last one I hear. In written feedback, the FDA stated they do not make a distinction between phases provided a clinical trial is adequate and well-controlled. And all three of these studies appear to be adequate and well-controlled. So the FDA doesn't really care if it's a phase 2 or phase 3. They actually really care about the study design more than anything. So pretty interesting stuff. So where it stands right now is this molecule is before the FDA, and we're hoping by the end of the year, it'll be approved. They've hired a sales force now. They have over 100 people hired now by Apellis that are the sales force. They have a whole marketing team. I'm actually on their marketing team as well for developing a speaker deck. And we submitted our primary findings now in New England Journal of Medicine. So pretty cool to be on a paper in the New England Journal of Medicine. Again, a small kid from South Dakota. I sat in that same chair as you guys 10 years ago. And it's pretty neat to be publishing in places like this, right? There's always competitors. So what's the rest of the story? There's always competitors. So you say, okay, that was the C3 story. Where else are we looking at? Well, what about C5? If I go back and show you, that's another choke point, right? This is another a place where if you could block here, you could really block that downstream cascade. Well, there's always competitors. So I'll tell you a story of this one. This is Zimura, made by Iveric, and they are very much on the tails of Apellis, looking for a approval for their C5 inhibitor for geographic atrophy. They are now the second company that has positive phase 3 data. Their phase 2b/3 GATHER1 study was positive. Now they've actually fully recruited their GATHER2 data, which I'll show you in a second here, the GATHER2 trials. And their phase 2b/3 trial was this right here, and looked at 2 different doses of this Zimura, and it's a C5 inhibitor. One was a 2 milligram dosing, and it showed a 27% reduction at 1 year. And they had a 4 milligram dosing, which also showed about a 27% reduction at 1 year. And based on that, they have now fully enrolled their GATHER2 trial, which is a 2-year trial, a very interesting design. They went forward with a 2 milligram dosing, intravitreal injection every month for 1 year. And then because Apellis will likely get an every other month indication, these guys are smart. They want also an every other month indication. And so in year 2, patients are broken out and be either continuing on monthly therapy, or they can be randomized to every other month therapy in the second year. And all this can be compared against sham, which is down here. Fully enrolled, and we will know the results by the end of this year as well. So it's gonna be very interesting to see the C5 versus C3 story over time. And these are huge, huge stakes here. I mean, these are billion-dollar drugs. All right, just show you one last case here just to drive it home again. So another patient, 86-year-old, she's 2200 on the right side, 2030 on the left. This is one of my absolute favorite patients. It breaks my heart. So look at that geographic atrophy, right? So 2200 on the right side. You can see all this area of hyperautofluorescence at the edge here. You know this lesion is going to continue to grow over time. That's the right eye. And what I really care about is this left eye. Look at that. That's a rough looking eye. This patient is desperate for any type of treatment we can give her. She's an artist. She's an awesome artist. She makes me watercolors. She's just a sweetheart patient. And if I could do anything to help her, I would do it in a heartbeat. So I hope we hopefully have a solution for her that we can actually give her by the end of the year. I'll show you the OCT in her, and you can see there's such a beautiful view of the choroid capillaries underneath there, disorganized outer retina. You can see a little bit of foveal contour there. That's the right eye. And if I go back over to the left eye here, same thing, you get that kind of diffuse thinning of the retina, loss of photoreceptors. Then when it gets to the fovea, you'll see this little bump right there, or you can see just a few working photoreceptors on that left side. Just remember what we do here makes a difference, right? The clock is ticking. This is a patient time lapse over 4 years. And the other thing you got to remember with geographic atrophy, it is a wildfire. It's not a slow burn. It's a wildfire. And the longer amount of practice, the more sad it is to watch these patients do this over time. Pretty sad. So just give you the rest of the story. So now it's before the FDA. Oaks and Derby, Philly all are applied together. It's really interesting. Used to be you submitted to the FDA in paper form, and now you do it all electronically. So the data submission went out about 2 weeks ago, at the beginning part of June, actually a week and a half ago at the beginning part of June. And now it's at the FDA's door, and they're going to do one of 3 things. They'll approve it, they'll reject it, or they'll ask for more data. And we'll know more in about 3 or 4 months. So stay tuned, and hopefully I'll have more of the story next time I come. So thank you very much for the invitation to come talk, and I'd love to answer any questions. So thank you guys. Please.
Thank you very much for this. Dr. Faraci gave our residents this talk about 4 or 5 years ago, and he let slip that he did, the retinal surgery. So I like that. Our graduates are screwing up with that.
Whoa.
So my late question. One is, I know it's very preliminary, but just projecting to the future, do you anticipate the injections to be a treat extend or an ongoing monthly or bi-monthly? Like, is there ever going to be an endpoint where you stop injecting? Right?
Super awesome and very insightful question. The question is, in typical retinal care right now, we do treat and extend for almost everything. Wet AMD, RVO, DME, DR, we do treat and extend. We're lucky for these patients to get less injections over time, right? This will be the first time where we're probably going to be just monotherapy, and it's not going to be treat and extend. The protocols for both the C5 and C3 inhibitors were either monthly or every month dosing. And so the label will either be monthly or every month dosing, depending on what the FDA says. There's more efficacy in monthly dosing in the pegcetacoplan, and there'll probably more efficacy, I'm guessing, in GATHER2 for monthly dosing. So I'm guessing this will be monthly therapy for these patients for the rest of their life, which is a big burden, right? And it's 0.1 cc's dosing. So it's not 0.05. And those in the retina space know that 0.1, the eye doesn't like 0.1. And so doing that over and over and over again is not the most healthy thing. Yeah, George, yeah. Yeah, exactly, yeah.
So I think it's a a couple weeks ago, there was a publication looking at that in ophthalmitis rates in one European country with national data set. They found that over the past 15 years, the rates about the same, but the different causes change. Now, appropriately, individual injections rate is obviously much higher. It's much higher because of the volume. Seemingly, if you start doing injections for the plethora of dry patients, we're going to see things like that.
Oh, 100% agree with you. Just in general, even in my hands, my rate of endophthalmitis is about 1 in 2,000. And, I do sometimes 40 to 50 injections per day. So if you do 40 to 50 injections a day, you get to 2,000 fairly quickly. And so you get several endophthalmitis a year. And all of a sudden, if I have these dry AMD patients coming in and they're getting bilateral injections for the rest of their life, you're going to have endophthalmitis. The interesting thing about the formulation right now is it comes in a vial and it has to be drawn out. And because that's the way it went to the FDA, it's not going to be pre-filled for a long time, because what you submit to the FDA, you have to keep that for a long time. So it'll be that drawing out process of the vial, which is also a contaminant risk for there. It's usually a little bit larger needle too, because of the fact it's very, 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 very viscous. And so injecting a volume of 0.1 in the eye with a very viscous solution, they actually have a larger bore needle, which I also think a higher rate of endophthalmitis. These are going to be older patients. These are going to be your oldest patients with GA in general. They're going to be your 80 and 90-year-olds. So I think all those are risk factors. Yeah.
Same matching ganglion.
Hey, good to see you. Yeah, of course.
In the right eye, that's the side. We had an extensive workup, ended up having a lot of blockage and had some sort of stent. They didn't call it an endarterectomy, basically. It was like
Yeah, so super good question. So the question is, there's all these compounds, plaque, centriole, or all these other. In general, I would say in the phase 2 trial, you never know because they're never super selective. In the phase 3 trial, there's such strict criteria for these patients to be included. I would almost say no and put into the second one. The phase 2, I'm sure you could find some ones not to start our study. Yeah, good question. And the other question, would it work in those patients? I don't know.
It's very dense.
This is the serious question. I'm getting nervous now.
I'm gonna take up 10:20. I'll be there in
There's no
like.
more time for, can someone
Okay,
fall off the
bye.
chair, please?
Yeah.
Yeah, no kidding. Yeah. Yes. Yes.
Because I've seen so many emails from him about this drug.
Yeah. It's kind of a little bit controversial. Yeah.
So you did present vision.
Yeah. Yeah, it's a good question. So you know why I didn't present vision? Because I didn't even capture vision. At the 1 year mark, it wasn't even a primary or a secondary endpoint. It's going to be a secondary endpoint in the second year. Yeah.
Right, but they did collect it.
They collected it, but they don't actually. So this is a good question. When I present the data, one of the points I had, because I knew the company was going to ask that same question, the C5 inhibitor, the Iveric was going to ask the same question. They purposely did not. They collected the data, but they didn't actually analyze the data so they could actually be ambiguous, ambivalent about it, ambiguous about it.
So let's see. So trying to channel my non-embodied.
Yeah.
So
I can feel the pain coming.
If you take this area of the decreased area of expansion and you correlate it to RPE cells, it turns out that at the 18-month endpoint, it's about 200 RPE cells difference between the treatment arm and the sham arm. And the patients are not going to notice any improvement. So, right, so you're going to be doing every month, and they're going to come in at about 6 months and say, I'm not better.
They're going to,
Of course, it's your endpoint because you don't want, they're not worse, which means, but so it's going to be constant political work with the patient to tell them, no, you're not going to get better. We're just trying to keep you from getting worse. And based on the difference between the sham and the treatment arm, you're aware of the Alzheimer's drug, Adulam or whatever.
Yeah.
Right? And so, that had a lot of bad press when it got approved.
Yep.
And there is going to be if this gets approved, there's going to be a similar, some people are going to do the same thing they did with that, right? And so that drug's totally failed because it never got taken up by the marketplace. It's done.
Totally agree with you. Yeah.
Done. So just comment on that.
Yeah. So a couple of points. So his points are really well taken. So first off, the great thing about retina right now, if you have DME, you have RVO, you have wet AMD, you're actually getting vision back, right? You're giving these injections, the patients are tangibly getting better. You can show them the OCT, you can see show them. This is not going to be that. This is going to be more like treating retinopathy, right? We're just treating global retinopathy. You're giving patients injections, and there might be 20/20 at baseline, but they have severe NPDR, but they're getting better, but they don't know it. So it's going to be that constant buy-in for patients. And so your point's really well taken. So if a patient's not getting better, they're going to show up for their monthly injections. And even though it's statistically making sure they're not getting worse, is that going to be enough for the patient to have the motivation to come in the wintertime in Kentucky to get their injection and down in Ashland or something like that? I don't know. The patient who's lost vision in one eye, who's already had the phobia, are completely obliterated by GA, that patient's gonna be motivated. But the average patient, it might be a really hard sell. And then the other comment is about, the 1 year. So if there was roughly in the extrafoveal lesions, there's about a 25% reduction in GA progression. It'll be really interesting to see the 18-month and especially the 1 year data. And these patients are followed out to 3 years in the Gale study. And so I'm hoping over time that curve diverges even more so that you can actually save more RPE cells over time. Yeah, super good question. I don't know the attendant costs whatsoever. So you can imagine it's not going to be cheap. Yeah, it's a really good question. So they're having the discussions. I don't know the brand name yet, although they know the brand name, and they're having the cost discussions right now. Yep. It will be interesting. Very interesting. Yeah.
So I have a problem what Dr. mentioned, which is you're saying that the patients are not getting any. They're just not getting any worse. They are actually getting worse. It's just
true. It's slowing down. True.
They're not plateauing, right? They're still getting worse.
True.
Not getting it as bad as if they weren't getting shot.
Absolutely fair.
So I think that's going to be a really difficult sell
Mhm.
unless there is a plateauing after on you that you find in year 2 or 3 when you have a more
Right.
extended period of time. I do have a couple of questions, channeling a little bit of my body.
Yeah, please. All right. I can feel more pain. All right. Yeah.
My first question is, how was the GA calculated?
Yeah, it's all based on fundus fluorescence, and it's a GA squared, millimeter squared.
Right.
Yeah.
And so that didn't include the area of hypo.
No, nope. Yep, just hypo.
And then my second question is regarding endophthalmitis. We're assuming that we're all talking about endophthalmitis. This is a drug that blocks complement, so there's going to be some maybe a possibility increased risk of infections. What did you see?
Yeah. So awesome. Thank you for bringing that up. And I should have brought it up earlier. So in the phase 2 data, when we went to Philly, we were hoping to not see really high rates of endophthalmitis. And the reason why it was a concern was exactly what you said. If you think about it, part of the reason why we don't get endophthalmitis is the complement system, right? It's part of the way that we clear infection. And so if all of a sudden you're blocking one of the ways we clear infection, are we just going to open the floodgates for bacteria? And thank goodness in Philly, we did not see that, nor did we see that in Oaks or Derby. It was not at any higher rate of endophthalmitis than it would be in an average study for anti-VEGF injection. Yeah, thankfully. Yeah, but that was a big concern. Great points. Yeah. And then the other thing I would say is that, I think we're going to finally start to look at those other parts of vision rather than just Snellen. So these patients are not getting better on Snellen, but if you look at things like contrast sensitivity and low luminance deficits, those are things that really affect visual quality, but we don't measure. At least I don't think about my typical clinic. But when you look at these patients, that was really where this drug shined. Those things that we don't really measure that often, especially contrast sensitivity and low luminance deficit.
How about reading?
Yeah, that also too. Yep. Those 3 things are the big 3 things, which are hard to measure in a busy clinic. Great. Thank you so much.
Thank you so much for that great discussion. We'll have a quick break until about 11 o'clock now, but I do have a couple of announcements. Number one, make sure to get your CME credit. This is not for the text, it's CME. So there is a general information sheet with that, and there's an evaluation online that you have to do as well. So just make sure to do that. And thanks again to the 3 first years who had excellent presentations. You set the bar pretty high for the second set.
Hi, everyone. We're going to have a break and then expect to be back between 11 o'clock and 11:05. Please be sure to visit our vendors next door. We do have plenty of coffee and they love to talk. So please ask them questions. See what's up. Thank you.